And hopefully, yep. And it lets you leave the meeting. So we now are recording, and I will go back to my questions. What are the parameters a doctor uses to diagnose TN? And this comes from people saying, you know, my pain's, you referenced yourself, a pain in the ear, pain in the neck, pain in different places. Is the MRI required? Like, how exactly does a doctor come to the diagnosis of trigeminal neuralgia?
That's a great question, and it's got many layers to it. And the first layer is, what do you mean by trigeminal neuralgia? And that should be a redundant question, but it's not, because people use the term trigeminal neuralgia in two general ways, which makes things terribly confusing. If you think about neuralgia, that's a nerve kind of pain. And nerve pain is, well, can manifest in many different ways. But if you have nerve pain or neuralgia, and it's in the face, which is the part of the body where the trigeminal nerve provides sensory function, clearly any nerve pain in the face can reasonably be called trigeminal neuralgia. And many physicians use that very broad, loose criteria. I think many of you know that when we talk about classical trigeminal neuralgia, which is kind of what surgeons think about when they think of trigeminal neuralgia, because that's a condition we actually can help with surgical procedures. Classical trigeminal neuralgia is a very specific set of symptoms. And as you might imagine, we'll review those in a moment. As you might imagine, there's in life and in medicine, there's gray zones. So while there is types of trigeminal neuralgia that are very different than classical trigeminal neuralgia, there are those types that are somewhere in between. And is it more classical or is it more general? So what is classical trigeminal neuralgia? That's a condition defined in various different sources, including the International Classification of Headache Disorders. And it refers to a condition where the face pain confined to the trigeminal distributions, forehead, cheek, jaw, and jaw goes up towards the front of the ear, forehead goes to the top of the head, but on one side. So pain in that distribution that's characterized by short, brief attacks of pain lasting no more than 2 minutes each. Many times those pain attacks are seconds or even instantaneous, but they don't last more than 2 minutes. Now, 2 minutes of trigeminal neuralgia pain will feel like an hour, but if you put a stopwatch on it, 2 minutes is kind of the limit for this classical trigeminal neuralgia diagnosis. That pain comes on sporadically out of the blue, or it can be triggered by simple things like touch, talking, drinking, any kind of simple contact or movements. So it can be triggered or spontaneous. The pain usually comes in what we call exacerbation. So it may last for days or weeks or months and then disappear. Now, when it disappears, if you've just been taking some herbal medicine and then the pain disappeared, you'll credit the herbal medicine. But perhaps it was just the coincidence that the pain went away, because it often does disappear. And it may go away for weeks, months, or even years before the next attack. And the next set of attacks might go on for weeks or months again and then disappear again into another remission. Over the years, those remissions become shorter and the exacerbations become longer. The pain attacks usually stay very much the same as the original ones, but perhaps just more frequent and more severe, and sometimes a bit more extensive in the face, but don't really change a lot in character. And another feature of classical trigeminal neuralgia is that the pain almost always in the early stages of the disease gets better or disappears with the standard anti-epileptic drugs that are used, like Tegretol, carbamazepine, Neurontin, gabapentin, and similar drugs. So those are the criteria for classical trigeminal neuralgia. Then there's patients with that kind of pain, but there's additional pain that's kind of in between those severe brief attacks. And that used to be called atypical trigeminal neuralgia, which is what's typical, what's atypical. It's not a good terminology. More recently, the terms have been differentiated to type 1 or type 2 trigeminal neuralgia, which again is a bit vague because type 1 and type 2 are differentiated between more or less than 50% brief attacks of pain. And how do you define 50%? Is that 50% of the pain, 50% of the time? It's a bit vague. So I think most surgeons like to consider classical trigeminal neuralgia just with those first set of symptoms I described. And then we consider how much additional pain is there beyond that. So does a person also complain about an hour of achiness in the pain after the brief attack? Does a person complain about a bit of numbness in the affected area? Does some of the pain go deep into the ear or even the back of the head or down the neck? Those are all features that make the pain less and less classical TN and more atypical of that diagnosis. And then there's the other extreme where patients may have a few attacks of brief pain, but the biggest problem is a more continuous, long-lasting pain that lasts maybe hours at a time. That type of pain is complicated because you can have that kind of pain if you have a bad tooth. You can have that kind of pain if you have a sinus infection or a bad temporomandibular joint or an inflamed parotid gland or other conditions or structural problems. But you can also have neuralgic pain that lasts for prolonged periods of time. And that usually doesn't respond so well to the medications. So the bottom line is, when you're asking what is trigeminal neuralgia diagnosed with, then you first have to say, well, what type of trigeminal neuralgia are you speaking of? Classical TN, non-classical TN, or other trigeminal neuralgias that are more general. In terms have been used, including idiopathic trigeminal neuropathy, atypical or idiopathic facial pain. So there's a list of possible causes for the pain. Unfortunately, as a neurosurgeon, besides helping with direct the diagnosis, we really don't have a lot of good surgical success. The more atypical the pain is, or not typical of classical trigeminal neuralgia. Certainly some patients with trigeminal neuralgia, it's classical plus some constant pain, we call that atypical trigeminal neuralgia, may be helped by surgeries about half the time. People with really no intermittent brief attacks of pain, or their primary problem is this constant long-lasting pain, they are less likely or even unlikely to be helped by surgeries. So again, complicated question. First of all, I got to define what TN is, and then there's lots of criteria for the different subtypes of the condition.
I don't know if any of these questions are uncomplicated, but we'll find out.
Yeah, and you know what you're hearing, it's not like I'm just telling you what all the doctors know. This is a common problem throughout medicine. We get 1 hour of trigeminal neuralgia lectures in medical school, and you may not see a patient with trigeminal neuralgia for the first many years of your family doctor practice, for example. And certainly other specialists, even some neurologists, don't see a lot of trigeminal neuralgia. And as well intentioned as we all are, things we don't do a lot of, we aren't as good at. And so again, you come back to these support groups and these information sources, they can be really valuable. I hate to suggest patients go and use Dr. Google and come in with reams and reams of papers from the internet. But in these rare conditions, often doing your research and advocating a little bit for yourself is really important.
I did, if anyone's interested, the International Headache Scale you referenced, I put a link to their page on trigeminal neuralgia in case anybody's
excellent.
interested in following up. So you mentioned family doctors, neurologists. What other doctors can diagnose trigeminal neuralgia?
Well, I would love it if dentists were good at this. And some are. I get several referrals from dental specialists, oral surgeons. But way back when I sort of was introduced to real trigeminal neuralgia practice with Dr. Janetta in Pittsburgh, the statistic was that about a third of our patients had misguided intervention, let's call it. Dental extractions, root canals, and things like that, which in retrospect were clearly for classical trigeminal neuralgia. And if you've got pain here that feels like there's a knife sticking in your tooth, who are you going to go see? A dentist, of course. And unfortunately, that hasn't changed a lot. We still see a lot of our patients, probably a third of them, have had dental procedures for their trigeminal neuralgia. Educating dentists is a good thing. So dentists have a big responsibility, and I guess the other sort of take-home message is if you go to see a dentist and they say your tooth looks perfectly fine, but if that's where you think the pain is, I'll take it out for you. It's not going to work. And you may actually end up having a new type of pain, because anytime you do damage to the body, it can backfire and be a source of new pain. So, so that's a big responsibility they have. Now, of course, they see most of their practice people with facial oral pain. So it's not always easy for them to differentiate what's trigeminal and what's not. But the bottom line is if you've got pain in a certain place, but that place looks normal, don't make it abnormal by a surgical procedure by the dentist.
Staying with the dentist thing, just before you go off that, can trigeminal neuralgia be triggered or caused by dental work?
Oh, that's a great question. So again, like everything, the answer is it depends. So if you're asking, can a dental procedure cause trigeminal neuralgia? Yes, but I'm talking about nerve damage pain. So neuralgia caused by damage to the trigeminal nerve or a branch of the nerve that causes nerve damage pain. And that's a risk with dental extractions and things. That's a different type of neuralgia pain. It's usually a constant aching, burning kind of pain in the affected area. And it's quite clearly related to the procedure because it starts very quickly after the procedure and it evolves from that moment and maybe gets worse, maybe even spreads a bit, but it's centered from that point of injury. You can get neuralgia at any point that's injured. I think you were probably asking, can classical trigeminal neuralgia be caused by this? And the answer is no. Classical trigeminal neuralgia is usually caused by an abnormal connection between a blood vessel and a nerve, with the blood vessel just pulsating up against the nerve, irritating the nerve system. That's there for years before the system gets aggravated enough to cause the first attacks of pain. Now, if your trigeminal system has been aggravated by years of compression, at some point it's likely going to develop TN, and a little bit of extra irritation from a dental procedure might just push it over the edge. Similarly, a car accident or something like that, where there's facial trauma. But that is not likely the cause, but an aggravating factor, if that makes sense, the differentiation. It doesn't cause it, but it aggravates the condition that's been developing. And often it's confusing because was this pain related to the dental procedure or a car accident, for example, or was this pain just coincidental to those things? So the timing makes a bit of a difference too, but it's really unusual for a dental procedure to cause, or a dental procedure won't cause classical trigeminal neuralgia.
We were all told, at least everyone I've spoken to has been told, you have to have an MRI. So is there a specific type of MRI that's used in diagnosis? Will any MRI work?
That's a great question. I've been doing this for a few decades now, and when I started doing trigeminal neuralgia surgery, we didn't do MRIs for patients. Back then, the teaching was you would do an MRI if the person came in with symptoms that were not classical. So if you had a lot of numbness in that painful area, that's more likely, that's more neuropathy pain, we call it. And if you had a lot of numbness, that might be because of a tumor pushing against your trigeminal nerve. Interestingly, a blood vessel pulsating against the nerve causes classical trigeminal neuralgia, brief episodes of pain. Whereas a tumor that's always pushing against the nerve causes more of an achy discomfort or pain in the face. It's not as intermittent and often some numbness as well. So in the old days, an MRI was only if you had symptoms that were not classical, to make sure there wasn't a tumor, which we'd find in a couple of % of people. Then MRIs got a lot better. And there's a point to this answer. So it's a long answer, but it gets around to the point. And the MRIs got a lot better. So you could actually see the blood vessels and not just the big tumor. MRIs didn't used to be as good as they are now. So now we're at the point where an MRI can show the fibers of the nerve leaving the brainstem, going across a fluid space, and then disappearing into a space in the bone on the way to the face. And it can show big, medium, and even some smaller blood vessels very nicely with special sequences called MR angiography or CIS and Fiesta images. CIS is CISS and Fiesta is like a party. With those images, you can see those blood vessels really clearly and see the contact of the blood vessel on the nerve. Now, there's a catch to all this. First of all, stepping back, classical trigeminal neuralgia is diagnosed by the history and the absence of neurological problems on examination. If you have the right history and nothing abnormal on your examination, then you have classical trigeminal neuralgia. It doesn't matter what's causing it, that's what you have. And 99% of the time, that's not due to a tumor or a mass pushing on the nerve. So, and most of the time that's caused by a blood vessel compressing the nerve. So the problem here is if you get an MRI to identify trigeminal neuralgia, well, first of all, you should have that label before the MRI based on your story. And your diagnosis should not change after the MRI, except to say you do or don't have a tumor, or you do or don't have multiple sclerosis, things that are clearly seen on the MRI. The question about can you and should you use the MRI to diagnose the blood vessel compression, I want to emphasize this again. You don't need to see the blood vessel compression to have classical trigeminal neuralgia. So the diagnosis is still the same. And I think that's important because as our technology has gotten better, we can see these blood vessels. Doctors have, especially non-specialists in neurosurgery, have taken the extra step and saying, well, if there's no blood vessel there, then it's not classical trigeminal neuralgia. I'm not going to refer you to a surgeon. And I've seen lots of patients like that when I look at the MRI, or if I look at the nerve at surgery, there is a blood vessel there. I've seen a lot of MRI reports from across the country where the blood vessel compression is not identified, but it's clearly there to my eye, and I can prove that based on a couple of thousand operations. So it's a bit problematic if you rely on your MRI to make your diagnosis. You're using it to rule out other problems, and then you need to have it examined. If you're looking at it for surgical decision-making purposes, you need to have it looked at by someone who's got experience looking at these nerves, and it's probably best a neurosurgeon who does these surgeries. There's one other important point. A large percentage of people have a blood vessel touching their nerve, the nerve that's not being affected by trigeminal neuralgia. So blood vessel can be there by coincidence. So again, it comes back to how important that initial question you had, Jane, about how do you make the diagnosis of trigeminal neuralgia? It's based on the clinical story. And the use of the MRI is complicated, and I think you want to use it to rule out things like a tumor, things like multiple sclerosis. But if you've got trigeminal neuralgia and you want to consider the surgical options, the MRI should be interpreted by a surgeon.
Switching to, I'm not muted, switching to medications. Why doesn't the medication work right away? And I think we're all used to, oh, I'm sore, take a Tylenol, it works. I've had surgery, take a Percocet, it works. Why doesn't TN meds work like that?
So you have to go into something I vaguely remember from first year medical school, pharmacokinetics. That's how does the drug behave in your system. And in this respect, the effectiveness of a drug like carbamazepine or Tegretol, and all of these drugs, depends on how much is in your bloodstream. And how much is in your bloodstream depends on how much you take, how much of it's absorbed through your gut into your bloodstream, and how quickly you get rid of it, either metabolizing it in your liver or peeing it out in your kidneys. So all those factors have an effect. And with a drug like carbamazepine or gabapentin, it takes 5 doses of that drug for the amount in your bloodstream to reach what we call a steady state. And a steady state is, well, let's go back. If you take 1 dose of Tegretol, you get a little bit of rise in your blood system, and then most of it gets kicked out of your body. Then you take your 2nd dose, you get a little rise, and most of it gets kicked out. The 3rd dose, and by the time you take your 5th dose, it kind of stays about the same level throughout the day in, day out. So it takes usually a couple of days for your body to accumulate enough Tegretol in the bloodstream to give you the result of that dose. Now, that dose, maybe it's 1 or 2 pills a day, might not be enough. And if you increase the dose after 3 or 4 days, it might take you 3 or 4 more days to get to the new steady state or that new accumulation in your bloodstream. And if that still isn't working, well, maybe you need 4 pills a day. And so you need to take another 3 or 4 days to get up to 4 pills a day. That can be a real problem if you've got horrific pain and you want an effect right away. We'll get to that in a moment. One of the reasons we don't just say, well, let's just start at 4 pills or let's just start at 6 or 8 pills a day is because while you're going to get to that higher dose faster with a higher dose, it's still going to take a couple of days to get your steady state. Your body's also not getting a chance to, well, get used to the medication. It's more complicated than that. The breakdown of these drugs causes breakdown products that cause most of the side effects. And if your body can metabolize these drugs better, which takes a bit of time, then you get less side effect from the medication. And that's why we like to slowly build up the dose and warn people, if you're having side effects, just give it a bit of time because they'll likely diminish a bit over the next couple of weeks at the lower dose. That goes out the window once you get to high doses of medications, because no matter how good your metabolism is, you're going to get side effects at higher doses. The issue of pharmacokinetics means you have to gradually build up the dose of medications in the system to avoid the side effects, and don't expect this to work overnight. It's going to take 3 or 4 days for the dose to kick in. Now, that said, let's say you're on a lot of trigeminal neuralgia medications and you've increased your dose and you have a breakthrough of pain and you have to go to emergency. You go in there, there's not a lot of options they have for you. What drug can you give quickly that's going to have an immediate benefit? For those of you who've had this experience, you probably know going in there for classical trigeminal neuralgia, getting a shot of morphine or similar drug often doesn't do much besides knock you out. It's not very good for neuralgia pain. The best treatment is to get you a higher dose of the anti-seizure drug, and the standard one given intravenously, and we can actually get your steady state in an hour or 3 hours or 6 hours, is by giving you an intravenous dose of dilantin or phenytoin. We don't have an intravenous carbamazepine or intravenous gabapentin, but we have intravenous dilantin. So we can increase that dose very quickly in your bloodstream by giving it to you intravenously. So that's helpful. The other thing that can be helpful right away in emergency for classical trigeminal neuralgia is to get an anesthetic shot into the nerve right under the skin for the area that's affected. That's easy if it's V1 or the ophthalmic branch of the trigeminal nerve. You get a needle injection of local anesthetic here. It's easy for cheek pain. The nerve leaves the skull, comes out under the skin right down here below the eye. You can freeze that area. For the most common type of trigeminal neuralgia location, the lower teeth, the tongue inside the mouth, I get an oral surgeon to come in, and they put a dental freezing in the nerve. It's just inside the jaw, between the jaw and the teeth, and they put some freezing in there. That can buy 6-8 hours of, or even longer, of pain relief, while the other drugs might kick in. So that there's the pharmacokinetics have an effect on how well you can treat this problem emergently as well.
I know that's you've jumped ahead to another question, which is great, but that is something we hear often, is that people go into the emergency room and are not able to get support. Some people, the Facial Pain Association has a protocol. I know people who printed it out and take it in, and the doctors are like, no, we can't follow an online protocol. Is there anything a patient or an advocate going in with a patient can say, or someplace they can point an emergency room to help them to realize that there is something emergent that can be done, especially if the emergency room is not familiar with this?
Yeah, this has been such a huge problem lately. You can imagine, I'm sure some of you have had this horrible experience, and I've heard of it many times in many settings. You go into emergency now, and no one can even come in with you. Mm-hmm. You've got 10, you can't even talk because it hurts so much. And the person who can actually help isn't allowed in the building. And that's been a problem for all sorts of issues related to COVID. Hopefully we're past that, but getting specific to your question, you're a little bit, on the one hand, at the mercy of who's ever on the staff that day. Are they open to suggestion? Do they have experience with trigeminal neuralgia? And they're all experts and well-intentioned, but not everyone's expert in this. And make two other points here. One is, again, a lot of this depends on what your diagnosis is. If you've got trigeminal neuralgia of the classical sense, then the things I just talked about in terms of intravenous dilantin, local anesthetic injections can be very helpful as a stopgap measure to perhaps a more definitive, even surgical procedure. If you've got other types of neuropathic facial pain, and what I didn't mention was people who get what's called post-herpetic neuralgias. They get a herpes zoster infection, shingles, and then that can be painful for the rest of their lives afterwards. These treatments I'm talking about don't really work that well for that at all. That kind of leads to the second point here. What would the ideal scenario be? And I try to suggest this, and I don't think it's practically available to everybody. The ideal is that you have a treatment plan in place, because a lot of people with trigeminal neuralgia, no, let's back up. Everybody with classical trigeminal neuralgia is going to get worse. That's another hallmark of this condition. Not true for some of the other neuropathic face pain conditions that might run their course and disappear with time. Classical TN always gets worse. With that in mind, it makes sense to have access to a specialist locally that can say, yes, this is your diagnosis, and here's what we're going to do when things get worse, including here's what we're going to do if you go into a crisis. So in Manitoba, it's kind of easy. The patients I see that neurologists or family doctors see, send for us to meet with, we'll tell them, you know, if you get into a crisis, go to emergency, but give us a call. And then we might have one of our team go and meet them down in the emergency, or at least talk to the emergency doctors and say, yeah, this person's got TN. If these things work, great. If they don't work, call us, and we might even offer surgery at this point, which we've already discussed at a clinic appointment before we get into a crisis. That doesn't always work. Sometimes the patients don't call the office, or it's a Saturday, they go to emergency, and they have all the same troubles you've just described, Jane. But that would be the ideal if you had sort of a preset plan and a specialist advocate who could step in if things aren't working. I know things aren't ideal, and most of you don't have that luxury. So the best you can do is have some ideas here of what might work. And if you had either a family doctor or a neurologist who understood that, and you could call them when you go to emergency and say, hey, we're going to emergency, can't take this pain anymore, they might be able to touch base with the emerge doctor. Paperwork is hard to get. You know, a generic paperwork from an excellent association like the TNA, you'd think would be helpful, but for a lot of emerge docs, that's just a piece of paper from Dr. Google. It might be a situation that if you had a specialist or even a family doctor willing to say, yes, you've got trigeminal neuralgia, yes, it's classical, yes, this is what we would suggest you do if you have things getting worse, having a copy of that letter might be helpful, as opposed to trying to call them on a Saturday night when you're in emergency and they're not available. Practically, I haven't seen that happening, but that you know, try to figure out what you might be able to do.
Someone in the chat asked, carbamazepine or time release, pros or cons, is one better than the other?
Great question. I don't know. And I don't know, and I'm confused about it because I've seen people say, I can only take sustained release. I cannot take sustained release because it works or doesn't work. So it's very individualized, just like all these TN treatments. You might find that one version works better than the other. Might have more or less side effects with one versus the other. Same with one drug versus the other. So a lot of it's trial and error. So ideally, you try either carbamazepine or gabapentin, and if that's not working, then try the other. Excuse me. In the same way, a gradual increase in the dose. Should mention here before I forget, you never want to stop these drugs cold turkey. You want to decrease the dose in a similar way for two reasons. One, if you decrease it too quickly, you might suddenly get an explosion of pain because you didn't realize the pain is actually being subdued by the medication. The other very important reason is that if you withdraw it too quickly, you can get withdrawal reactions and even a seizure. So you want to stop these drugs over about a week or 2 weeks, gradually reducing the dose. The exception to that is if you get a rash that we think or you think might be related to the drug you're taking. Those rashes, while they're annoying and irritating, they can actually become life-threatening, particularly related to carbamazepine and dilantin. So if you get a rash or reaction to your medication, you can stop it suddenly if you have to. But generally, we do it slowly if it's an option.
At the conference back in July in Vancouver, there was talk about some new medications for TN. Any update on that?
For a few years, I've been asked to participate in a drug trial for a drug, and it's probably about 5 years now. And every year we do all the paperwork. We got ethics approval 3 times now. And as we're about to start, they withdrew their study, the company, the drug company. And that happened again about 6 months ago.
Mm.
So I don't know of any new drug that's at that phase of testing, which is sort of the final phase before they can sell it as an effective drug. At this point, there's a longer and longer list of anti-seizure drugs. And I see more and more patients on different anti-seizure drugs and the standard first line ones, the carbamazepine and gabapentin, Tegretol, Neurontin. I don't know of any evidence that they're any better than those two standard ones. I think for the most part, they're all much more expensive. Certainly what we typically do is try the standard ones first, and if they work, we keep with them. Again, remember, those drugs have been used for decades for people with epilepsy, with proven safety. And these other drugs that have been introduced are also proven safe through a lot of trials, but none of them have proven to be better than those first two I mentioned. So if you're having good benefit from the one drug without much side effect, keep up with it. If you're not having good benefit or a lot of side effects, then it's an issue of trial and error with a long list of these anti-seizure drugs.
So to segue from drugs to surgery, somebody in the chat posted that they have been told you must try a minimum of 3 medications before being considered for surgery. True or false?
It depends which textbook you're reading. Short answer is false, but I must say I do remember in the 1990s, maybe even the 80s, reading neurosurgery textbooks that specifically said that. And I think in general, our approach has evolved to the point where there are 3 reasons in my mind to consider surgery for trigeminal neuralgia. One is the pain's not under control, despite your best efforts. 2 is, and we'll get back to what that means, 2 is the side effects from your drugs are intolerable. Or 3 is you don't want to live with this disease for the rest of your life. So I will, on occasion, operate on people who have classical trigeminal neuralgia. We've confirmed there's a blood vessel, an artery compressing their trigeminal nerve. We therefore know the success chances for an MVD to cure this are very good. And they've got pretty good pain control. They're only on 800 milligrams of Tegretol a day, but they're not as sharp and as crisp as they feel that they used to be cognitively. Maybe their balance, maybe their energy levels. And they don't want to continue with that drug forever and likely need a higher dose in the future. So they said, let's just do the surgery now rather than later. I think that's reasonable. I think it's less reasonable to take that same person and say, we can do a rhizotomy that's going to give you an average of a couple of years of relief. In that situation, I would say you're probably better off continuing with medications. So who defines how much medications you take or when you have surgery? It's really the person with trigeminal neuralgia who defines that. And I don't tell people that they've got enough pain. I don't tell people they're suffering enough from their side effects. I don't tell people whether or not they should live with this forever or not. That's their decision to make. But I do need to tell them what the statistical chances of success are in the short term and the long term. I need to tell them what the statistical chances of a complication are, both short term or permanent. I will say one other thing on that is that I don't think I've ever operated on a patient with trigeminal neuralgia who's had it for less than a year. And there's a very specific reason for that. Most people with trigeminal neuralgia, if they first get the pain, it'll usually disappear sometime in the first year. They'll get it going to remission. Mm-hmm. It's very rare for the first episode to be continuous for the rest of their life. They almost always have a remission. Even if they don't, if it's classical trigeminal neuralgia, most people will still have classical trigeminal neuralgia a year later. But many people with pain that is so bad that they want to have surgery in the first year because the medications don't work will end up having a different type of neuralgic pain in the near future. It's exceptionally rare for someone with classical TN to need an operation the first year, because usually they go into remission and or the medications work. And I'm very concerned about doing surgery for somebody who I can't help. That's obviously a mistake in my mind. So if you don't have classical trigeminal neuralgia, in fact, don't have any version of trigeminal neuralgia, perhaps you have atypical facial pain or idiopathic facial pain, or even something else, and I operate with a trigeminal neuralgia surgery, that was a mistake. So I want to make sure the person actually has the condition before I offer them the surgery. So that's the reason we never offer surgeries. And I think that that's true. Never has been never. That's in the last several decades of doing surgery in the first year. Likely, if they need surgery, they don't have classical TN anyway, and surgery probably won't work then.
Is the MVD an option for someone if no compression shows on the MRI? And to stay on the same MVD topic, if the TN comes back, when or should or would a person consider a second attempt at an MVD?
Yeah, and again, a complicated question and a lot of factors there. Is it classical trigeminal neuralgia or not? Is the vascular compression not there because a radiologist who reads MRIs of the trigeminal nerve a couple times a month said it's not there, or because a neurologist who has a radiologist who has a lot of experience said that, or because a neurosurgeon reviewed it and says I don't see the nerve compressed or not? So that's a lot of it depends answers there. So it's really important to have that information in hand. What's the actual diagnosis? What's the actual picture show? So let's say we have classical trigeminal neuralgia and no blood vessel compression. I can see the arteries I'd usually be worried about, and they're here and they're there and they're not on the nerve. So I can account for everything that's there. There's no prominent vein compression, which is a rarer cause of trigeminal neuralgia. The nerve looks like it's just sitting by itself, no compression. I'll tell that person the chances of me helping you with a decompression is really small because I don't think I'm going to find anything. And I've done many surgeries on patients where I don't find something, and it's been in a unique situation with people who have multiple sclerosis. We're doing the operation not to move a blood vessel, but to actually cut the nerve partially. And so the preoperative MRI doesn't show a blood vessel, and I can confirm that at surgery. It's not there. So there are certainly circumstances if the blood vessel is not there on the MRI to a trained eye, then it's not there. So an MVD is not going to help. Now, then you move into, well, what are the options? And is it wiser to have a nerve damaging procedure is the other type of surgery if an MVD. Now, MVD again is that microvascular decompression, the surgery to take the pulsating blood vessel and move it away from the nerve so it still pulsates, but it's not banging up against the nerve anymore. So if there's nothing to move away, we have a surgical option of rhizotomies, which are nerve damage procedures. And there's a list of different ways we can do that. We can talk about that a little bit later, sorry. One of the ways is to do that surgically, look at the nerve and partly cut the nerve. And that's probably the most effective long-term way to damage the nerve, but it's also an operation as opposed to simpler day procedure for the other rhizotomies. Before we talk about rhizotomies, going back to your question, what if you've had a prior MVD and the pain is still a problem? Well, again, the answer is it depends. Did the pain come back immediately after the surgery? And the surgery had no benefit at all. Was the surgery done well? And I say that in that we've had experience seeing a lot of patients who have had an MVD, and we do a second MVD and say, oh, the blood vessel's still there. And we can often see that or usually see that on the MRI, special angiography MRI, or cis fiesta sequences, and actually see the nerves and the blood vessels in contact still. So again, it depends, was it done well? And what if the surgery was done 10 years ago, but the pain's coming back now? With a few decades of experience, I've seen a few patients now where the pain's coming back because the Teflon, which is used as a spacer to keep the blood vessel away from the nerve, can be the source of irritation on the nerve. Very rarely, that Teflon can get inflamed. Now, the Teflon is very inert, meaning it doesn't react in the body. It's part of some heart valves that are sewn into the heart. It's part of some joint replacements. So there's a lot of experience of the Teflon living in the body forever without a problem, but rarely it can be the source of some inflammation. And that inflammation can irritate the nerve and cause recurrence of pain. So we look for signs of that on the MRI. And if that's the case, we'd like to remove that Teflon and get the nerve free of any irritation. The other option is if we're going to go and redo the MVD, with the expectation we're probably not going to find much, but want to double check because it looks like Teflon might be touching the nerve. There may or may not be a blood vessel there. In those circumstances, we always talk about the option of, at the same time, cutting the lower third or half of the trigeminal nerve back at the brainstem, which provides excellent chances of permanent pain relief, but at the cost of some loss of feeling. Not loss of strength or movement, but loss of feeling in the face. So like most of the good questions you have, the answer is usually it depends on all these circumstances.
That's the answer for everything. We are out of time. I'm going to go out on a limb and say people are okay to give us another 10 minutes, give or take. And I'm going to condense into the questions that were, I've got a few left, so the ones that were asked several times. So one of them is a nerve stimulator. Is it worth considering?
Yes, with the caveat, the nerve stimulators have been a problem. Sticking them physically into the nerve goes up through the cheek typically, and they often work their way out of their target location. So we can get a needle up there, thread the wire through the needle and leave the wire up against the nerve, but as you move your jaw, that wire gets displaced. So even if it worked, it often doesn't work after a while because it's not in the right place. Now, in terms of it working, it's still what we would call an investigational or experimental treatment. There hasn't been good enough proof to show that it works in the long term, or good enough proof to figure out who it works well for. Is it work for this type of pain, but not that type of pain? There's just not enough concentrated experience or research to figure it out if that's true or not, because it's not done very often. So it's a reasonable thing to consider, usually done through a pain clinic when all else has failed. But I don't know who the right person is for that in terms of what type of pain. It's certainly not a better option for classical trigeminal neuralgia compared to medications, MVD, or rhizotomies. For the other types of face pain, nerve damage pain, post-herpetic neuralgia, idiopathic facial pain, it's been tried for all of those. It's not really clear which of those people are going to benefit, but in general, it's less than a third of people have any meaningful, lasting relief, which is true for almost any investigational treatment. Any
value to medical cannabis, or any comment on that, the use of medical marijuana?
Yeah, again, it depends. It's trial and error. I've not seen, well, let me tell you, the patients who've come for trigeminal neuralgia surgery, I don't remember seeing anybody who said, well, I was using cannabis for a while, it really was working, and then it stopped working for my classical TN. So I don't think it's a useful option for people with classical TN. I'm sure there's exceptions there, but I haven't seen them. For the other types of face pain, the neuropathic face pains. And what I mean by neuropathic is basically anything that's not trigeminal neuralgia in the classic sense. There's mixed reviews. It's not the panacea drug that everyone gets better with. I know people in the pain clinic will use a version of that called nabilone that is a derivative of cannabis, and it has some good effect for some people. So like all these drugs, it's a trial and error thing. If it works for you, that's great. If it doesn't work for you, if you do it carefully and perhaps with the aid or direction of a physician, it's worth trying, particularly for the non-typical pain conditions. I think one of the concerns always with, and this is going on a whole different tangent, but one of the conditions we see quite a lot of is people with what's called idiopathic facial pain or atypical facial pain. Mysterious, horrible condition with at least a couple hours of terrible pain every day, usually more than that, and no clear cause for it and no clear good treatment for it. I'm always a little cautious about recommending cannabis-related treatments for them, because for no clear reasons anyone understands, many of those people have significant problems with depression and anxiety. And how they're related, I don't know. Nobody else does either. But there's no question it's a common co-occurrence. And cannabis-related treatments for people with depression or anxiety can sometimes help, but very often make things worse. So that should be sort of coordinated by someone who's looking after the whole package of treatments, as opposed to, getting all your treatments at one place and then going to the pot shop and getting cannabis on the other, on your own and seeing what happens. Probably better do it with collaboration with your care providers.
Anything to recommend for people who have anesthesia dolorosa post a TN procedure?
Oh, yeah. Short answer, no. We've got a couple of patients now we're considering, should we do even more invasive treatments like thalamotomies? Like, can you believe that? Basically burning a hole in the brain, in the thalamus, to try to relieve the pain. Those are pretty desperate measures. There's some evidence that it might help, but anesthesia dolorosa, for those of you who don't know, is horrific continuous pain in the area that's lost feeling because of nerve damage. An example many people may have heard of is phantom limb pain. If you lose your hand in an accident, the nerves, of course, to the hand are severed, and you may have horrific pain in the hand that you no longer have. Well, the same can happen in the face. If you damage the nerve going to the face has no feeling in that area. And that area can usually just have loss of feeling, no big deal or not a huge problem. But sometimes the brain makes up a feeling for the feeling that's absent, and that pain can be horrific, and that's anesthesia dolorosa. And unfortunately, there are no clear treatments. People have tried nerve stimulators, usually doesn't work because the nerve's damaged. People have tried all sorts of medications, and of course, even to the point of putting stimulators into the brain, deep brain stimulators, or doing burning holes in the brain into the thalamus. So no, I don't have any first-hand experience, and that's something that we refer a patient to the pain clinic to try all the list of drugs that may or may not help. Jane, I'm available to stay longer. I would like to say, I hope this session's been useful to people listening. I think these are so valuable and important. I'd be thrilled if you invite me back anytime again, and either to continue on with the list or start with a whole new one, or if there's a special topic people want to have a more in-depth presentation about, be it a 10-minute video presentation I can do about how certain procedures done or things like that. I think doing these, I think you've really struck on something here, opening this up to a bigger population of people who can get out there when they can't get to a place that they can get to their laptop, and even if you're recording it at a later date. So I just want to applaud you again, and I know you've been dealing with this condition for a long time, but the fact that you're helping so many people, it's really a great thing. So thank you very much. But I've got a bit more time. I don't know how much longer you want to keep going though.
I have one last question we'll ask, but even just to tie on to what you said is just to give a shout out to the late Marion Guzik, who started the Trigeminal Neuralgia Association of Canada, not at a young age and with not only TN, but other health issues. And we are here today because of her passion and her desire to bring this along. And everything we do is really a tribute to that woman's heart and her care for this. She connected many of us, including myself, with you many years ago before this whole virtual world existed. So Marion, at a grassroots level, was really the pioneer behind much of TN advocacy that we see in our country today. And I just want to shout out to her because I know her family is still, carrying the message forward.
I am so glad you said that. I remember Marion really well, and I remember meeting her in my office at Foothills Hospital. I worked in Calgary, and she had trigeminal neuralgia and battled with that, and she also had a strong personality and said, like, this is a problem. Why is it taking so long to get help? And how come I didn't know about this sooner? And what are you doing about this? And she gave me heck in her nice way. And I couldn't help but think at that time, I'm sure this is exactly the conversation Peter Janetta was confronted with by the founder of Trigeminal Neuralgia Association of the States. But Marion took it to her own level in Alberta and then across the country. And she was recognized by the Trigeminal Neuralgia Association for her tremendous efforts. And as you mentioned, it wasn't easy for her, and she didn't have all the benefits that we have right now with this technology so much at hand. And it's I think we have to thank her and remember her for those efforts. And I certainly do. And thank you for reminding us all and keeping her memory alive.
Okay, last question. I'm going to two-part it. I have a young dog that wants to eat, so he's trying to get my old dogs awake. If he succeeds, we're doomed. Person living with trigeminal neuralgia, anesthesia dolorosa, whatever, over the course of years, can that make them more susceptible to their body responding neurologically with things like peripheral neuropathy, neuropathic itch, things like that? And also, do you think that there may be a genetic component or some sort of genetic or familial link to trigeminal neuralgia?
There's a weak genetic familial link. There's a very slight higher risk statistically of having trigeminal neuralgia if family members have had it. It's not clear how or why. Some have speculated that might be something with your physiology. Others have speculated it might be because of the tendency of the blood vessels to be a bit longer. It's not clear, and it's quite a weak tendency. So it's generally unlikely you're going to pass it on to the next generation. In terms of if you've been suffering for a long time with these horrible pain conditions, statistically, it's not more likely to cause you to have other conditions or be associated with those, except, and certainly not with other neuropathic conditions. Those are trigeminal neuralgia and anesthesia dolorosa are very specific to that nerve for very specific reasons. There are other conditions where neuropathy pain can be more widespread and come here and there, but not with trigeminal neuralgia, except for the caveat, suffering with these conditions is not easy. And being sick generally makes you more susceptible to other sicknesses. So I certainly wouldn't want to minimize the overall effect these pain conditions have on people's overall wellness. And I think we all know that your overall wellness has a lot to do with your resilience to other health problems. So not a direct relationship, but certainly pain and suffering has an impact on our general health for sure.
We're going to wrap at that point. I'm definitely taking you up on your offer to come back again. We'll probably pick you up in the new year because we head into November and the holiday season from here. But we'll definitely bring you back. There are a few people in the chat have just been commenting saying, thank you so much. This has been so helpful. You've confirmed diagnosis, you've answered questions for them. So people are reflecting in the chat that this has been very, very helpful to them. On our part, we will get this recording uploaded as long as it worked. So as long as everything's good, I will get it uploaded and we will post to our website and then share the link for that. So thank you all, Dr. Kaufmann. Thank you so much for giving up part of your Saturday afternoon.
You're welcome. It's a real pleasure.
Hopefully next time you can come in full color instead of black, gray, and red.
I don't, you know, I've got 3 lights out in my office, so I think that's probably the issue. So
it's pretty neat though, actually.
But for anybody's watching the game tonight, here we go, Winnipeg.
The red?
We're playing Toronto tonight.
Oh, we won't go there. I have family in Toronto. I just won't go there. It's a vote of contention.
We'll do our best to beat them.
I'm an hour from Montreal and then Ottawa, so it's a huge bone of contention here, but we will see. Thank you again. We will be in touch. If you are not, as most of you probably know, we've moved away from membership, but we do maintain an email list through the Trigeminal Neuralgia Association of Canada. And we will be sharing through our email list. We are also the only registered charity in Canada that funds and supports trigeminal neuralgia research across the country. So please do stay connected with us. And Dr. Kaufmann, we will see you in the new year for sure.
Looking forward to it. Bye, everybody. Thank you.